Welcome to PT 771. In this presentation, we'll discuss experimental group designs. Just to review, the group designs that we'll be discussing in this particular presentation are classified as experimental research. And remember that experimental research is characterized by controlled manipulation of at least one independent variable by the researchers. The dependent variables or the outcome measures are collected under very controlled conditions, and we're looking to determine if the groups are statistically significant, because those differences between levels of the independent variable that achieve statistical significance are unlikely to have occurred by chance. And remember, when we look at statistical significance, it's also important to determine if those differences are clinically significant as well. The experimental group designs that we'll discuss in this particular presentation are commonly seen in randomized controlled trials, which sit very high on the evidence hierarchy, just below systematic reviews and above non-experimental designs like cohort studies, case control studies, case series or case reports, and editorials or expert opinion. With regard to group designs, there are several assumptions that are typically made in these type of trials. The first is that we're dealing with group data, and we're really not looking at how individuals performed in that trial. And when we're looking at group data, we're concerned about if the differences between the groups achieved statistical significance. We also know that in terms of these groups that we see in studies, there's likely going to be variability in terms of age, health status, motivation, and other personal factors. We try and mitigate some of the variability in these groups through random sampling of the population. And ultimately, what we hope to be able to do is generalize our findings, to the populations that we treat in a physical therapy clinic. And how well we can generalize our research findings to the populations that we treat, we call that external validity. We've already mentioned that randomized controlled trials, or RCTs, sit very high on the evidence hierarchy, primarily because from an experimental group design, they really provide the strongest evidence for determining whether or not clinical interventions work. These studies are typically classified as being prospective and experimental. And again, experimental research and from a prospective consideration, that really means that the independent variable is subject to controlled manipulation by the researcher. Remember, the independent variable is going to be the treatment or the intervention that we're going to see in the study. And we're always going to see at least two levels in a randomized controlled trial, where subjects will be randomly allocated to receive one of those two levels. That could be a treatment and a comparison treatment, or it could be a treatment versus a control. The dependent variable, which is the outcome measure, is also going to be collected under very controlled conditions. We randomly allocate subjects again to mitigate some of those personal factors that we see in the groups, and hope that we see a washout with that, and these groups are equal in terms of these personal factors. We always classify RCTs as being experimental again because of that manipulation of the independent variable. And while RCTs do provide strong evidence, they're not always the best designed to answer some clinical questions. So for example, if you think about how would we determine the effects of smoking, there's some ethical concerns there, right? We would never randomly allocate subjects to a smoking group. We would never do that. So cohort studies or case control studies may be more effective in answering some of those type of questions, especially if there's an ethical concern associated with this design. In this presentation, we'll discuss several different experimental group designs. And the first one we'll discuss is a single factor experimental design that's characterized by one independent variable with typically two levels being evaluated in the study. The most common type of design here is what we see as a pretest-posttest control group design, And just below that second bullet, you see a notation. And the notation is really characterized by how that design of the study is developed. The R's indicate that participants were assigned randomly to the two groups. The O's represent observation or measurement, and this would be characterized by the dependent variable in this study. You see 1x in that first line, and that represents an intervention. And the blank just below that X in the second row represents the control group, really an absence of intervention in that particular trial. The intervention and the control, therefore, constitute two levels of the independent variable. Another term for this type of design is a between subjects design or a between groups design, because the differences of interest are those differences that occur between the subject groups. We also commonly see this intervention versus a control modified in clinical research, and you can see that down at the bottom where you see a notation of X1 and X2, where we're dealing with two comparable or perhaps even competing interventions to determine which one is more effective. We still see randomization, observations in a pre and post fashion. The other design that we typically see with an X1 and X2 could be due to the fact that we don't want to withhold intervention in the form of a control because there may be ethical concerns with that. And if you think about an example of, if we want to randomly assign patients who are referred by a physician for physical therapy, it may not be ethical to withhold physical therapy intervention from one group. And so instead of that, we may actually look at two competing treatments, right, that make really good sense, and we want to determine if one intervention was more effective than the other. And for each design that we present to you, we'll try and provide an example from the physical therapy literature that really fits that particular design. So this particular study that's in front of you was a randomized controlled trial characterized by a pretest post-test design. And in this particular study, subjects with osteoarthritis of the knee were randomly assigned to one of two groups. And so the first group received supervised exercise in the clinic, individualized manual therapy, as well as a home exercise program. And then the second group, or the comparable group, received just a home exercise program. And so the dependent variables in this particular study that were evaluated, again, in a pre-test, post-test manner, were the 6-minute walk test, as well as the WOMAC. And the results showed that the individuals who received the supervised exercise, individualized manual therapy, and home exercise program had a much better outcome in terms of the WOMAC scores compared to the group that just received a home exercise program. Again, because this design deals with manipulation of that independent variable in a randomized fashion, this randomized control trial sits very high on the evidence hierarchy and would suggest that the addition of supervised clinical exercise as well as individualized manual therapy would be a useful adjunct to a home exercise program in trying to optimize outcome in patients who have knee osteoarthritis. The second type of group design that we'll discuss will be a post-test-only control group design. And this type of study is commonly used when we're unable to take pre-test measurements. It's classified as a randomized controlled trial between group design, again, because the difference of interest are those differences that occur between the subject groups. If you look at the notation for this particular design, we see, again, the R's indicate that participants were randomly assigned to the two groups. The X represents an intervention, and the blank in the second row below that X represents the control group. And the O's represent the observation or assessment of the dependent variable. And again, this is a design that's commonly used when we're unable to take pretest measurements. For example, if we're dealing with individuals post-injury or post-surgery. So the study we present to you on this slide is an example of a post-test only design that we described on the last slide. And so in this particular study here, subjects following ACL reconstruction were randomly assigned to one of two groups. The first group received neuromuscular electrical stimulation to the thigh musculature. They also performed volitional exercise, and then the second group performed volitional exercise alone without an addition of the neuromuscular electrical stimulation. And so this is an example again of a randomized controlled trial that has one independent variable with two levels, two different forms of intervention. But the interesting point here is that all we see is a post-test analysis of the dependent variable. And the dependent variables in this particular study were strength of the thigh musculature as well as gait parameters. Again, if we're dealing with individuals prior to surgery, if we evaluate strength or we evaluate gait, that likely isn't going to give us an accurate depiction of how these individuals are functioning. And so again, if we're dealing with groups post-injury or post-surgery, this post-test only design probably makes the most sense. And so in this particular study, the group that received the neuromuscular electrical stimulation had stronger quadriceps muscles as well as a more normal gait pattern than those in the volitional exercise group alone. Another type of group design is a single group pre-test, post-test design. In this particular notation here, in that first bullet, you see that first O. That first O really signifies an observation of the dependent variable prior to intervention. The X indicates the intervention, then that second O indicates another observation of the dependent variable following the intervention. And unlike the pre-test, post-test control group design and the post-test only control group design, this single group design is neither an RCT nor between groups design. Because there is only one group, there is no opportunity for random allocation of participants in the groups, nor is there any between group comparisons to be made. Instead, comparisons are made within the single experimental group, making this a within group design. And for this type of a design here, if we find that the results of the study appear to be positive, the next logical step would be to carry out a randomized controlled trial that has at least two levels of the independent variable or intervention that we saw in this particular study. So the study presented on this particular slide is an example of a single group pre-test, post-test design. And the purpose of this study was to determine the effects of manual therapy on pain and disability in patients who had primary non-acute acromioclavicular joint pain. And so this study was characterized by initially the administration of several outcome measures in terms of pain and disability to a group of 13 patients. Then these patients were treated for an average of 6 sessions with a manual therapy approach that addressed impairments of the shoulder girdle and cervical thoracic spine. Following the completion of the intervention, subjects were then assessed again with the dependent variables looking at pain and disability, and what they determined was that statistically significant and clinically meaningful improvements were really observed in all of the dependent variable outcome measures at 4 weeks and then again at 6 months, right, following that short series of manual therapy interventions. And if you look at the conclusion based upon the author's findings, they mention that this approach to management of patients with AC joint pain really needs to be verified by a randomized controlled trial. And so I think that this study really provided the impetus for that, a more larger, more robust trial that looks at a comparison of manual therapy to some competing intervention. Another type of group design is the non-equivalent control group design. And this particular design is used when a non-random control group is only available for comparison. And so if you look at the notation that we see again here, the O's indicate a pre- and post-test analysis of the dependent variable. The X indicates an intervention, and then the blank in the second row below that top X represents the control group. The dotted line between the group indicates that participants were not randomly assigned to groups. Thus, this design is not considered a randomized control design. It is, however, a between groups design because the comparison of interest is between the two non-random groups. An example of a non-equivalent control group design is the study that you see in front of you by Case Smith, where they were evaluating the effects of a school-based occupational therapy program on student handwriting in terms of legibility and speed. And so this particular study, in terms of dependent variables, again, they looked at handwriting legibility and speed prior to and following intervention. And it was a non-equivalent control group design because the two groups were really differentiated by whether or not they received occupational therapy. And so one group who received occupational therapy, these were students who were referred primarily to an occupational therapist because of handwriting legibility concerns. The non-equivalent control group was a group of students who didn't get referred to occupational therapy, but they were identified by teachers as individuals who had handwriting legibility concerns. And so this could easily have been turned into a randomized pretest, post-test control group design by just randomly allocating subjects to occupational therapy. However, that wasn't done here. And so because the randomization wasn't done, it falls into that non-equivalent control group design. Nonetheless, this study did show that the individuals who received occupational therapy did demonstrate improved handwriting legibility. And so I think that this is another design that would hopefully indicate the need for a randomized control trial to truly determine if occupational therapy can play a role in improving handwriting legibility. Another design that we commonly see in the literature is a time series design. And this is used to establish a baseline of measurements before the initiation of treatment to either a group or an individual. When a comparison group is not available, it becomes important to either establish the stability of a measure before the implementation of treatment or document the extent to which the measure is changing solely as a function of time. And so the notation we see here, prior to the X, which indicates the intervention, we see 4 assessments of the dependent variable. Then we see the intervention, and then following the intervention, we see 4 assessments of the dependent variable, again, to determine how well that dependent variable or how much that dependent variable has changed and how does it vary over time. The 4 measurements taken before and after the intervention provide a fuller picture of the status of the dependent variable than would a single pretest or post-test measure. So again, this is another group design, or it can be used in a single system design with one individual, where establishing the stability of the measure prior to the intervention would be important, and then looking at how that dependent variable changes over time following the removal of the intervention. An example of a time series design would be a study that might be used to evaluate the effectiveness of something like a COVID vaccine. And so prior to administering the COVID vaccine to a particular population, we would evaluate the number of new COVID cases, let's say once per week over the course of 4 weeks. Then we'd administer the vaccine, and then again we would track the number of new cases at several points in time following the administration of the vaccine. And that would help us understand whether or not the vaccine was effective at preventing the development of new cases. And again, having multiple measures of new cases prior to and following the intervention probably gives us a better picture of how well that vaccine did than if we just looked at one pre-test or post-test measure at the number of new cases. Having those multiple measures definitely gives us a better indication of how effective an intervention could potentially be. Up to this point, we've looked at single factor experimental designs, and that single factor means that we're looking at the effects of one independent variable. But what if we have multiple independent variables in a study and we want to look at the effects of that, right? So these multiple factor experimental designs are really used to determine the effects of the interaction between multiple factors or independent variables. And so the diagram on the right there shows you the design of a study that would potentially look at individuals following cerebrovascular accident or CVA who have swallowing dysfunction. And so we might have individuals with CVA who have swallowing dysfunction now randomly allocated to 3 different treatment groups. One could be a postural program, the other could be an oral motor program, and the third could be a feeding cues program. 3 different levels to that independent variable of group treatment. But what if we also want to determine if one type of therapist was more effective at implementing these type of training programs? And so we might have another independent variable in the study that looks at therapist. And so maybe therapist A is a speech and language pathologist and therapist B is an occupational therapist. And so this type of a study where we're looking at 2 different types of independent variables and the interactions associated with them would be classified a 2-factor design. 2 factors because the 2 factors relate to the 2 independent variables. It would also be a 3x2 factorial design, again because one independent variable has 3 levels. In this instance, it would be the different type of treatment group the patients would be allocated to, and then the 3x2, the 2 would be the 2 levels of the therapists, meaning we're looking at 2 different types of therapists in this particular study as well. So these multiple factor experimental designs are used in rehabilitation research all the time. And because of that, it's important that we have some understanding of how these designs look and some of the terminology associated with them. So in this particular type of study that we described on the last slide, where we're looking at the effects of 2 different types of therapists implementing 3 different types of treatment interventions for individuals following CVA who have swallowing dysfunction, right? We could ask a couple different types of questions. First, is one type of treatment more effective? The second question would be, is one type of therapist more effective? And then finally, is one type of therapist more effective with a certain type of intervention? So let's take a moment and evaluate how we would determine the answers to these particular questions. So now that we've explained the design of the study to you on the previous slides, let's add some fictitious or hypothetical data into a table now, and then we'll show you a graphical representation of that table down below. And so the dependent variable in this type of study would be the change in swallowing function in terms of %. And so we can evaluate swallowing function prior to and following intervention, and then determine how much of an improvement in terms of a percentage did we see in swallowing function. And so the numbers that you see in the table up top really relate to the mean improvement in terms of % of swallowing function. And so if we look at therapist A with the postural training group, you see there's a mean improvement there of 30 percentage points. If you look at therapist A in terms of oral motor training, you see there's a mean improvement of 40 percentage points. And if you look at the feeding cues program for therapist A, you see that there's an improvement of 50 percentage points. You can also see those improvements for therapist B as well for the 3 different treatments. If we look at the numbers outside of the cells, right, so if we take therapist A and follow it all the way down, you see there's a mean of 40 below that cell of 50 there for the feeding cues. That 40 really relates to a mean improvement of 40 percentage points for therapist A when we combine the effects of all 3 treatment groups. Therapist B had an improvement of 30 percentage points when we combine all 3 treatment groups. And then on the far right hand side of the treatment of the table, you see now 25, 35, and 45, and those really relate to the mean improvement in terms of percentage points for swallowing function for posture, for oral motor training, and then feeding cues when we combine the effects of both therapists in this study. And below you see the graphical representation of that. And so the questions again we would have is one treatment more effective? Is one type of therapist more effective? And is one type of therapist more effective with a certain type of intervention? So take a moment to review those 3 questions and see if you can figure out what the answers might be before moving forward. So we had 3 questions on the last slide that we asked you to reflect upon before moving forward. And so those first 2 questions, is one treatment more effective or is one type of therapist more effective? It's really looking at the effects of one independent variable on the dependent variable, and we call those main effects. And if we look at the 3 different types of treatment groups, again, the numbers outside those cells really relate to the mean improvements in swallowing function for each of the 3 treatment groups when we combine the effects of both therapists, right? So postural group improved 25, a mean of 25 percentage points. The oral motor group improved a mean of 35 percentage points, and then the feeding cues group improved a mean of 45 percentage points. And so is one treatment more effective? Sure, when we combine the data from both therapists, it appears that the feeding cues group is most effective, followed by the oral motor group, and then followed by the postural group. Is one type of therapist more effective? It looks like therapist A, who has a mean improvement of 40 percentage points in swallowing function when we combine the 3 treatment groups, is more effective than therapist B, who has an improvement of 30 percentage points when we combine the effects of all 3 treatment groups. And if you look at the graph on the bottom, it really helps us determine whether or not there's an interaction or not. And the interaction we relate to the question of, is one type of therapist more effective with a certain type of intervention? And many times in rehabilitation research, it's really the interaction that we're most concerned about. Right, and so in terms of the interaction, we note that yes, therapist A is more effective with all 3 types of interventions when we look at those mean improvement scores in swallowing function than therapist B. So if we look at how the results might show up in a scientific paper for this hypothetical study that we've designed here, you might read that there are main effects for both type of treatment and therapist. And remember, main effects refer to the effect of one independent variable on that dependent variable. We're not really mixing the 2 at this particular point. But what that means, if their main effects are present, is that one therapist is more effective than the other in implementing the training programs, and then one type of training program is more effective than the others. And that's truly the case, right? But there is no interaction between the type of treatment and the therapist, meaning that for each of the 3 different treatment paradigms or treatment interventions, right, we see that therapist A got better results than therapist B for each of the 3 different training programs. For this particular slide, we've changed the data set up a little bit for you. And so take a moment to study the results on this particular slide, which is different than the results on the last slide, and take a look and try and determine, are there main effects? Meaning, is one treatment more effective than the other? Is one type of therapist more effective than the other? And then is there an interaction? Which would mean that one type of therapist may be more effective with a certain type of intervention. On the last slide, we told you that there were main effects for both treatment and therapist, and that an interaction didn't take place. And when we say there is no interaction, it means that if we look at the effects of one therapist compared to the other, right, that one therapist is better at all three treatment programs than the other one in terms of outcome, right? So take a look at the data on this particular slide and look at those three questions and see if you can come up with what those results might be before moving forward. The data in that particular table, once you've had a chance to look at it, should show you that there are no main effects for either type of treatment or therapist. And what does that mean? When we say there are not main effects, we're looking at the effects of one independent variable on the effects of the dependent variable. And if we look at, let's just say, the three different training groups, treatment programs rather, we look at posture, oral motor, and then feeding cues, training programs. On the far right there, we determine that each group, when we combine the effects of the therapist, improved 30 percentage points in swallowing function. So all three groups improved, but there was really no difference, no main effect for group in terms of treatment. How about therapist? Right? Is one type of therapist more effective than the other? Well, when we combine the effects of all three treatment groups, we determine that there is not a main effect for therapist, meaning that one therapist was not more effective than the other. Again, when we combine those averages and look at the mean improvement in swallowing function, again, 30 percentage points improvement for therapist A and therapist B. So there are not main effects on this particular slide. The last fictitious data set we gave you, we said that there were main effects for both treatment in terms of the treatment received for the group, as well as the different types of therapists. And so much different on that last slide compared to this one. However, on this particular slide, we note that there is an interaction between the type of treatment and the type of therapist. And what that means is that even though there were no overall differences between treatment and therapist studied, certain therapists were considerably more effective when using certain types of treatments. And we can probably see that best on the graph below. And so if we look at therapist A, we note that they had the greatest improvement, right, in the postural training, in the feeding cues program. And so therapist A, that triangle denotes the feeding cues program. They had a 40% improvement in swallowing function with respect to feeding cues compared to therapist B, who had a 20% improvement. However, when we look at the postural training program, therapist B had a 40% improvement in that, while therapist A only had a 20% improvement with that. When we look at the oral motor training program, there were really no differences between the two therapists. And so in terms of, again, main effects, there was no difference in this particular data set in terms of therapist or training program. However, we note that therapist A was more effective with the feeding cues program, and therapist B was more effective with the postural training program. And again, that question of whether or not there's interaction could have the most utility, right, for us, because it would make most sense to determine if one therapist is more effective with one type of treatment training program. So in summary, when we look at a multiple factorial design, we're looking at the effects of two different distinct independent variables on a dependent variable. And in this particular case, we're looking at three different types of training programs for individuals who have a CVA and swallowing dysfunction. We're also looking at the effects of different types of therapists. We gave you two different types of data sets here that show you whether or not main effects are present or not, and whether or not there's an interaction present or not. We started the presentation by looking at single factor designs, and I think you can understand how probably both designs have utility in the rehabilitation physical therapy literature. This concludes our presentation. Thank you very much for your time and attention.